Morning everyone. So today I'm going to discuss the orthomyxoviruses, paramyxoviruses and rubella virus. So first is the orthomyxoviruses. So the orthomyxoviridae are a major determinant of morbidity and mortality caused by respiratory disease, and outbreaks of infection sometimes occur in worldwide epidemics. Influenza A is antigenically highly variable and is responsible for most cases of epidemic influenza. Type B may exhibit antigenic changes and sometimes causes epidemics. Influenza C is antigenically stable and causes only mild illness in immunocompetent individuals. So there are three immunologic types of influenza viruses are known, designated A, B, and C, whereas antigenic changes continually occur within the type A group of influenza viruses and to a lesser degree in the type B group. Type C appears to be antigenically stable. Influenza A strains are also known for aquatic birds, chickens, ducks, pigs, horses, and seals. For the structure and composition, influenza particles are usually spherical and about 100 nanometer in diameter, although virions may display great variation in size. The single-stranded, negative-sense RNA genomes of influenza A and B viruses occur as 8 separate segments. For the influenza C viruses, it contains 7 segments of RNA lacking a neuraminidase gene. So, neuraminidase gene, a sialidase enzyme that removes sialic acid from glycoconjugates. It facilitates release of virus particles from infected cell surfaces during the budding process and helps prevent self-aggregation of virions by removing sialic acid residues from viral glycoproteins. For its classification, for the genus Influenza virus A, it contains human and animal strains of influenza type A. For the influenza virus B, it contains human strains of type B, and influenza virus C contains influenza type C viruses of humans and swine. For the pathogenesis and pathology, influenza virus spreads from person to person by airborne droplets or by contact with contaminated hands or surfaces. The incubation period from exposure to virus and the onset of illness varies from 1 day to 4 days, depending on the size of the viral dose and the immune status of the host. So, viral shedding starts the day preceding onset of symptoms, peaks within 24 hours, remains elevated for 1 to 2 days, and then declines over the next 5 days. Infectious virus is very rarely recovered from blood. So, influenza infections cause cellular destruction of the superficial mucosa of the respiratory tract but do not affect the basal layer of epithelium. Complete reparation of cellular damage probably takes up to 1 month. Influenza attacks mainly the upper respiratory tract. It poses a serious risk for elderly adults, very young children, and people with underlying medical conditions such as lung, kidney, or heart problems, diabetes, cancer, or immunosuppression. For the uncomplicated influenza, symptoms of classic influenza usually appear abruptly and include chills, headache, and dry cough, followed closely by high fever, generalized muscular aches, malaise, and anorexia. So, anorexia is an abnormal loss of appetite for food. The fever usually lasts for 3 to 5 days, as do the systemic symptoms. Respiratory symptoms typically last another 3 to 4 days. The cough and weakness may persist for 2 to 4 weeks after major symptoms subside. Clinical symptoms of influenza in children are similar to those in adults, although children may have high fever and a higher incidence of gastrointestinal manifestations such as vomiting. For the pneumonia, serious complications usually occur only in elderly adults and debilitated individuals, so especially those with underlying chronic disease. Pregnancy appears to be a risk factor for lethal pulmonary complications in some epidemics. The lethal impact of an influenza epidemic is reflected in the excess deaths caused by the pneumonia and cardiopulmonary. So, pneumonia complicating influenza infections can be viral, secondary antibacterial, or a combination of the two. Increased secretions helps carry agents into the lower respiratory tract. For the Reye syndrome, it is an acute encephalopathy of children and adolescents, usually between 2 and 16 years of age. So the cause of Reye syndrome is unknown, but it is a recognized rare complication of influenza B, influenza A, and herpes virus varicella zoster infections. So, nasopharyngeal swabs and nasal aspirate or lavage fluid are the best specimens for diagnostic testing and should be obtained within 3 days after the onset of symptoms. So, first is the polymerase chain reaction or PCR, a rapid test based on detection of influenza RNA in clinical specimens using a reverse transcription polymerase chain reaction or RT-PCR are preferred for diagnosis of influenza. RT-PCR is rapid, sensitive, and specific. For isolation and identification of virus, the sample to be tested for virus isolation should be held at 4 degrees Celsius until inoculation into cell culture because freezing and thawing reduce the ability to recover virus. So cell cultures can be tested for the presence of virus by hemadsorption 3 to 5 days after inoculation, or the culture fluid can be examined for virus after 5 to 7 days by hemagglutination or immunofluorescence. So viral isolates can be identified by hemagglutination inhibition, a procedure that permits rapid determination of the influenza type and subtype. For rapid diagnosis, cell cultures on cover slips in shell vials may be inoculated and stayed 1 to 4 days later with monoclonal antibodies to respiratory agents. Rapid viral cultures can also be tested by RT-PCR to identify a cultured agent. So for the serology, routine serodiagnostic tests in use are based on hemagglutination inhibition and enzyme-linked immunosorbent assay or ELISA. The HI test reveals the strain of virus responsible for infection only if the correct antigen is available for use. For the prevention and treatment by drugs, amantadine hydrochloride and an analog rimantadine is the treatment and prophylaxis of influenza A. The NA inhibitors, zanamivir and oseltamivir and peramivir are useful for treatment of both influenza A and B. To be maximally effective, the drugs must be administered very early in the disease. Prevention and control by vaccines. First is the preparation of inactivated viral vaccines. So, inactivated influenza A and B virus vaccines are licensed for parenteral use in humans. Selected seed strains are grown in embryonated eggs, the substrate used for vaccine production. The reassortant virus, which carries the genes for the surface antigens of the desired vaccine with the replication genes from an egg-adapted laboratory virus, is then used for vaccine production. A cell-based vaccine using animal cell cultures became available in 2012, which overcomes some limitations of egg-based production. So next is virus is harvested, purified, concentrated by zonal centrifugation, and inactivated with formalin or beta-propiolactone. So vaccines are either whole virus, subvirion, or surface antigen preparations. The whole virus vaccine contains intact, inactivated virus. The subvirion vaccine contains purified virus disrupted with detergents. And lastly, the surface antigen vaccines contain purified HA and NA glycoproteins. And all of them are efficacious. For the live virus vaccines, a live virus vaccine must be attenuated so as not to induce the disease it is designated to prevent. A cold adapted donor virus able to grow at 25 degrees Celsius should replicate in the nasopharynx. A live attenuated cold adapted temperature sensitive trivalent influenza virus vaccine administered by nasal spray was licensed in the United States in 2003. So, use of influenza vaccines. Annual influenza vaccination is recommended for all children ages 6 months to 18 years and for high risk groups. These include individuals at increased risk of complications associated with influenza infection and persons who might transmit influenza to high-risk groups. The live virus intranasal vaccine is not currently recommended for individuals in the high-risk groups. Next is the Paramyxoviruses and Rubella virus. The Paramyxoviruses include the most important agents of respiratory infections of infants and young children, as well as the causative agents of two of the most common contagious diseases of childhood. So the morphology of Paramyxoviridae is pleomorphic with particles 150 nanometer in diameter, occasionally ranging up to 700 nanometer. The envelope seems to be fragile, making virus particles labile to storage conditions and prone to distortion in electron micrographs. The viral genome is linear, negative sense, single-stranded, and non-segmented RNA. The Paramyxoviridae family is divided into two subfamilies and seven genera, six of which contain human pathogens. The genus Respirovirus contains two serotypes of human parainfluenza viruses, and the genus Rubella virus contains two other parainfluenza viruses, as well as mumps virus. Newcastle disease virus, the prototype avian parainfluenza virus of genus Aviola is also related to the human viruses. The morbillivirus genus contains measles virus of humans and as well as canine distemper virus, rinderpest virus of cattle, and aquatic morbilliviruses that infect marine mammals. The henipavirus contains zoonotic paramyxoviruses that are able to infect and cause diseases in humans. Hendra and Nipah viruses, both indigenous to fruit bats, are members of the genus. So these viruses lack neuraminidase activity, and respiratory syncytial viruses of humans and cattle and pneumonia virus of mice constitute the genus Pneumoviruses. Para-influenza viruses are ubiquitous and cause common respiratory illnesses in persons of all ages. They are major pathogens of severe respiratory tract disease in infants and young children. So the infection may involve the nose and throat, resulting in a common cold syndrome. However, infection may be more extensive and may involve the larynx and the upper trachea, resulting in croup. Croup is characterized by respiratory obstruction caused by swelling of the larynx and related structures. The infection may spread deeper to the lower trachea and bronchi, culminating in pneumonia or bronchiolitis. Primary infections in young children usually result in rhinitis and pharyngitis, often with fever and some bronchitis. However, children with primary infections caused by parainfluenza virus type 1, 2, or 3 may have serious illness ranging from laryngotracheitis and croup to bronchiolitis and pneumonia. The severe illness associated with type 3 occurs mainly in infants younger than the age of 6 months. Croup or laryngotracheobronchitis is more likely to occur in older children between ages 6 months and 18 months. Newcastle disease virus is an avian paramyxovirus that produces pneumoencephalitis in young chickens and respiratory disease in older birds. In humans, it may produce inflammation of the conjunctiva. Recovery is complete in 10 to 14 days. Next is the laboratory diagnosis. First is the nucleic acid detection. Reverse transcription polymerase chain reaction or RT-PCR assays can be used to detect viral RNA in nasopharyngeal swabs, washes or aspirates, or lower respiratory tract specimens such as bronchoalveolar lavage fluid. Next is the antigen detection. Detection of viral antigens can be done in exfoliated nasopharyngeal cells by direct or indirect immunofluorescence tests. These methods are fairly rapid and simple to perform but are limited by low sensitivity and the range of viruses detected. Next is the isolation and identification of virus. A continuous monkey kidney cell line, LLC-MK2, is suitable for isolation of para-influenza viruses. Prompt inoculation of samples into cell cultures is important for successful viral isolation because viral infectivity drops rapidly. Lastly, the serology. Antibody responses can be measured using neutralization, hemagglutination inhibition or HI test, or enzyme-linked immunosorbent assay or ELISA test. Treatment and prevention. The antiviral drug ribavirin has been used with some benefit in treatment of immunocompromised patients with lower respiratory tract disease. Contact isolation precautions are necessary to manage nosocomial outbreaks of parainfluenza virus. These include restrictions of visitors, isolation of infected patients, and gowning and hand washing by medical personnel. No vaccine is available. Next is the respiratory syncytial virus infections. RSV is the most important cause of lower respiratory tract illness in infants and young children, usually outranking all other microbial pathogens as the cause of bronchiolitis and pneumonia in infants younger than 1 year. So the pathogenesis and pathology of the RSV replication occurs initially in epithelial cells of the nasopharynx. Virus may spread into the lower respiratory tract and cause bronchiolitis and pneumonia. Viral antigens can be detected in the upper respiratory tract and in shed epithelial cells. The incubation period between exposure and onset of illness is 3 to 5 days. Viral shedding may persist for 1 to 3 weeks from infants and young children, but adults shed virus for only 1 to 2 days. The spectrum of respiratory illness caused by RSV in infants includes inapparent infection, the common cold, bronchiolitis, and pneumonia. Bronchiolitis is the distinct clinical syndrome associated with this virus. Reinfection is common in both children and adults, although reinfections tend to be symptomatic. The illness is usually limited to the upper respiratory tract, resembling a cold in healthy individuals. RSV infections account for about one-third of respiratory infections in bone marrow transplant patients. Pneumonia develops in about half of infected immunocompromised children and adults, especially if infection occurs in the early post-transplant period. Infections in elderly adults may cause symptoms similar to influenza virus disease. Pneumonia may develop, and children who have RSV, bronchiolitis, and pneumonia as infants often exhibit recurrent episodes of wheezing illness for many years. Methods described for diagnosis of parainfluenza viruses are applicable to RSV. Detection of RSV is strong evidence that the virus is involved in a current illness because it is rarely found in healthy people. Detection of viral RNA or viral antigen in respiratory secretions is the test of choice. For the nucleic acid testing, it is the preferred method and is especially useful for adult specimen in which only small amounts of virus are often present. For the nasal secretion using the human heteroploid cell lines HeLa and Hep2, it is the most sensitive for viral isolation, and cells can be tested 24 to 48 hours by immunofluorescence or RT-PCR. Treatment of serious RSV infections depend primarily on supportive care. The antiviral drug ribavirin is approved for treatment of lower respiratory tract disease caused by RSV, especially in infants at high risk for severe disease. The drug is administered in an aerosol for 3 to 6 days. Immune globulin with high titer antibodies against RSV is of marginal benefit. Next is the human metapneumovirus infections. So it is a respiratory pathogen first described in 2001. Human metapneumovirus is able to cause a wide range of respiratory illnesses from mild upper respiratory symptoms to severe lower respiratory tract disease in all age groups. Human metapneumovirus infects only humans and is related to avian metapneumovirus that causes rhinotracheitis in chickens. The incubation period for metapneumovirus is estimated to be from 4 to 9 days. The duration of shedding is about 5 days in children and several weeks in immunocompromised hosts. Replication is limited to respiratory epithelial cells in infected hosts. So, these viruses are associated with a variety of symptoms of the respiratory tract. These symptoms cannot be distinguished from those induced by RSV. Children usually display rhinorrhea, cough, and fever and may develop acute otitis media. Lower respiratory tract illnesses may occur, including bronchiolitis, pneumonia, croup, and exacerbation of asthma. Healthy adults tend to develop cold and flu-like symptoms in response to metapneumovirus infection. The best specimens for detection of human metapneumovirus are nasopharyngeal aspirates or swabs. RT-PCR assays are the methods of choice. Detection of viral antigens in respiratory specimens by direct immunofluorescence staining is sensitive for children due to higher viral loads but poorer for adults. There is no specific therapy for human metapneumovirus infections and no vaccine is available. Next is the mumps virus infections. Mumps is an acute contagious disease characterized by non-suppurative enlargement of one or both salivary glands. Mumps virus mostly causes a mild childhood disease, but in adults, complications including meningitis and orchitis are fairly common. Humans are the only natural host for mumps virus. Primary replication occurs in nasal or upper respiratory tract epithelial cells. Viremia then disseminates the virus to the salivary glands and other major organs. The incubation period may range from 2 to 4 weeks but is typically about 14 to 18 days. Virus is shed in the saliva from about 3 days before to 9 days after the onset of salivary gland swelling. The clinical features of mumps reflect the pathogenesis of the infection. At least one-third of all mumps infection are subclinical, including the majority of infections in children younger than 2 years. The most characteristic feature of symptomatic cases is swelling of the salivary glands, which occurs in about 50% of patients. A prodromal period of malaise and anorexia is followed by rapid enlargement of parotid glands as well as the other salivary glands. Swelling may be confined to one parotid gland or one gland may enlarge several days before the other. Gland enlargement is associated with pain. Mumps causes aseptic meningitis and is more common among males than females. The testes and ovaries may be affected, especially after puberty. The diagnosis of typical cases usually can be made on the basis of clinical findings. First is the nucleic acid detection. RT-PCR is a very sensitive method that can detect mumps genome sequences in clinical samples. It can detect the virus in many clinical samples that have negative results in virus isolation attempts. RT-PCR assays can identify virus strains and provide useful information in epidemiologic studies. Next is the isolation and identification of virus. The most appropriate clinical samples for viral isolation are saliva, cerebrospinal fluid, and urine collected within a few days after onset of illness. Virus can be recovered from the urine for up to 2 weeks. Monkey kidney cells are preferred for viral isolation. For rapid diagnosis, immunofluorescence using mumps-specific antiserum can detect mumps virus antigens as early as 2 to 3 days after the inoculation of cell cultures in shell vials. For the serology, the ELISA or HI test is commonly used. Antibodies against the HN protein are neutralizing. ELISA can be designed to detect either mumps-specific IgM antibody or mumps-specific IgG antibody. There is no specific therapy for the mumps virus infection. Immunization with attenuated live mumps virus vaccine is the best approach to reducing mumps associated morbidity and mortality rates. Next is the measles or rubella virus infections. Measles is an acute, highly infectious disease characterized by fever, respiratory symptoms, and a maculopapular rash. Complications are common and may be quite serious. Humans are the only natural host for measles virus, although numerous other species, including monkeys, dogs, and mice, can be experimentally infected. The virus gains access to the human body via the respiratory tract, where it multiplies locally. The infection then spreads to the regional lymphoid tissue, where further multiplication occurs. Primary viremia disseminates the virus, which then replicates in the reticuloendothelial system. A secondary viremia seeds the epithelial surfaces of the body, including the skin, respiratory tract, and conjunctiva, where focal replication occurs. Involvement of the central nervous system is common in measles. Infections in non-immune hosts are almost always symptomatic. Measles has an incubation period of 8 to 15 days from exposure to the onset of rash. The prodromal phase is characterized by fever, sneezing, coughing, running nose, redness of the eyes, Koplik spots, and lymphopenia. The cough and coryza reflect an intense inflammatory reaction involving the mucosa of the respiratory tract. Koplik spots are the pathognomonic for measles. It is a small bluish white ulcerations on the buccal mucosa opposite the lower molars. The fever and cough persist until the rash appears and then subside within 1 to 2 days. Modified measles occurs in partially immune persons, such as an infants with residual maternal antibody. The incubation period is prolonged. Prodromal symptoms are diminished. Koplik spots are usually absent, and the rash is mild. Pneumonia caused by secondary bacterial infection is the most common life-threatening complication of measles. This occur in fewer than 10% of cases in developed countries, but is much more frequent in developing countries. SSPE, or the subacute sclerosing panencephalitis, is the rare late complication of measles infection. It occurs with an incidence of about 1 in 10,000 to 1 in 100,000 cases. The disease begins insidiously 5 to 15 years after a case of measles. It is characterized by progressive mental deterioration, involuntary movements, muscular rigidity, and coma. Typical measles is reliably diagnosed on clinical grounds. Laboratory diagnosis may be necessary in cases of modified or atypical measles. For the antigen and nucleic acid detection, measles antigens can be detected directly in epithelial cells from respiratory secretions, the nasopharynx, conjunctiva, and urine. Detection of viral RNA by RT-PCR is a sensitive method that can be applied to a variety of clinical samples for measles diagnosis. Isolation and identification of virus, nasopharyngeal and conjunctival swabs, blood samples, respiratory secretions, and urine collected from a patient during the febrile period are appropriate sources for viral isolation. Shell vial culture tests can be completed in 2 to 3 days using fluorescent antibody staining to detect measles antigens in the inoculated cultures. For the serology, ELISA, HI, and neutralization tests all may be used to measure measles antibodies, although ELISA is the most practical method. Vitamin A treatment in developing countries has decreased mortality and morbidity. Measles virus is susceptible in vitro to inhibition by ribavirin, but clinical benefits have not been proved. A highly effective and safe attenuated live measles virus vaccine has been available since 1963. Measles vaccines are derived from the Edmundston strain of measles virus and protect against all wild measles viruses. Next is the rinderpest. It is the world's most devastating disease of cattle. Was caused by rinderpest virus, a relative of measles virus. In 2010, rinderpest was declared to be eradicated from the earth after a successful global effort launched in 1994. These are represented the first animal disease and the second disease in human history after smallpox to be eradicated worldwide. It was accomplished by widespread vaccination programs and long-term monitoring of cattle and wildlife. Next is the Hendra virus and Nipah virus infections. Two zoonotic paramyxoviruses that represent a new genus, which is the Henipa virus, were recognized in the late 1990s in disease outbreaks in Australasia. Hendra virus, an equine virus, has caused many horses fatalities and a few human fatalities in Australia. An equine outbreaks in 2008 resulted in 2 human cases of Hendra virus encephalitis, one of which is fatal. Fruit bats are the natural host for both Nipah and Hendra viruses. Both viruses are of public health concern because of their high mortality rate, wide host range, and ability to jump species barriers. They are classified as biosafety level 4 pathogens. No vaccines or proven therapies are available. Next is the rubella or German measles virus infections. Rubella is an acute febrile illness characterized by a rash and a lymphadenopathy that affects children and young adults. It is the mildest of common viral exanthems. Infection during early pregnancy may result in serious abnormalities of the fetus, including congenital malformations and mental retardation. Classification of the Rubella virus. It is a member of the Togaviridae family and the sole member of the genus Rubivirus. Postnatal rubella. Neonatal childhood and adult infections occur through the mucosa of the upper respiratory tract. Rubella has an incubation period of about 12 days or longer. Initial viral replication probably occurs in the respiratory tract, followed by multiplication in the cervical lymph nodes. Viremia develops after 7 to 9 days and lasts until the appearance of antibody on about day 13 to 15. After the rash appears, the virus remains detectable only in the nasopharynx, where it may persist for several weeks. Rubella usually begins with malaise, low-grade fever, and a morbilliform rash appearing on the same day. The rash starts on the face, extends over the trunk and extremities, and rarely lasts more than 3 days. Transient arthralgia and arthritis are commonly seen in adults, especially sa women. Unusual complications include thrombocytopenic purpura and encephalitis. Clinical diagnosis of rubella is unreliable because many viral infections produce symptoms similar to those of rubella. Certain diagnoses rest on specific laboratory studies, like isolation of virus, detection of viral RNA, or evidence of seroconversion. So first is the nucleic acid detection. RT-PCR can be used to detect Rubella virus nucleic acid directly in clinical samples or in cell cultures used for virus isolation. Molecular typing can identify virus subtypes and genotypes and is useful in surveillance studies. Throat swabs are appropriate samples for molecular typing. Next is isolation and identification of virus. Nasopharyngeal or throat swabs taken 6 days before and after onset of rash are a good source of rubella virus. Using cells cultured in shell vials, viral antigens can be detected by immunofluorescence 3 to 4 days post inoculation. Next is the serology. The hemagglutination inhibition test is a standard serologic test for rubella. However, serum must be pre-treated to remove non-specific inhibitors before testing. ELISA tests are preferred because serum pre-treatment is not required and they can be adapted to detect a specific IgM. Rubella is a mild, self-limited illness and no specific treatment is indicated. Attenuated live rubella vaccines have been available since 1969. The vaccine is available as a single antigen or combined with measles and mumps vaccine. The primary purpose of rubella vaccination is to prevent congenital rubella infections. Next is congenital rubella syndrome. Maternal viremia associated with rubella infection during pregnancy may result in infection of the placenta and fetus. Infection during the first trimester of pregnancy results in abnormalities in the infant in about 85% of cases, but detectable defects are found in about 16% of infants who acquired infection during the second trimester. Inapparent maternal infections can produce these anomalies as well. Rubella infection can also result in fetal death and spontaneous abortion. Intrauterine infection with rubella is associated with chronic persistence of the virus in the newborn. The classic triad of congenital rubella consists of cataracts, cardiac abnormalities, and deafness. Infants may also display transient symptoms of growth retardation, rash, hepatosplenomegaly, jaundice, and meningoencephalitis. Central nervous system involvement is more global. The most common developmental manifestation of congenital rubella is moderate to profound mental retardation. Progressive rubella panencephalitis A rarer complication that develops in the second decade of life in children with congenital rubella is a severe neurologic deterioration that inevitably progresses to death. There is no specific treatment for congenital rubella. It can be prevented by childhood immunization with rubella vaccine to ensure that women of childbearing age are immune.